Hello guys, and welcome to your somatic symptom and dissociative disorders lecture. Those are actually two different types of disorders. They just got clumped into the same area in your book, and so off we go. We are going to have some simple objectives here. We're going to explore that nurse's role in the patient with somatic and dissociative disorders. So what can we do as nurses when these things present here? So let's talk first about somatic disorders. And some of the rules of engagement for somatic disorders is: one, the symptoms have to be beyond a medical explanation. So if the patient complains of polydipsia and they have diabetes, then they do not have a somatic disorder. They have diabetes, right? This is kind of one of those examples there. And then of course we have to add all of our favorite DSM-5 criteria, the one that says we have to have a causing significant distress and functional impairment for the patient. So it's not really a disease or a disorder until we have that significant distress and functional impairment. So here are the somatic disorders that we are going to explore some more. One is called the somatic symptom disorder. The next is going to be illness anxiety disorder. Then we have our conversion disorder, our fictitious disorder, and our fictitious disorder by proxy. So our somatic disorder, once more, there's a couple of things that we need to be aware of with all of our somatic disorders. And this is that they are more often than not primarily anxiety rooted. So when we take care of the anxiety for the patient, oftentimes these kind of underlying features will dissolve on their own. So we need to kind of be cognizant that this all stems from anxiety, primarily extends from anxiety, I should say. So oftentimes the patient will also have a traumatic event in their life or events that have led them to these disorders. And then there's this learning theory, which means that the patient is using these somatic disorders as a means of alleviating these stressors in various ways. So they're wanting to avoid a stressful obligation. Sometimes they're wanting to gain attention or seeking attention. And sometimes they're using this to alleviate a family stressor. And one example of this might be if mom and dad are in turmoil, I can have this disorder or a problem that's going to help kind of bind that family. So the parents can't really be fighting if they're taking me to the doctor and figuring out what's going on with me. So that might be a potential reason why a person would go to this somatic disorder there. So the first one here is a somatic symptom disorder. And this is where a patient has a significant focus on physical symptoms. So these are symptoms that, not signs. So one that we can't touch or with a objectifiable measure there. And these are like shortness of breath, pain, weakness, kind of just these non-objectifiable symptoms that the patient's having. And It is known to, you'll see this, I don't know why why the range is so big, but it's big on all of these. So it's estimated to affect 0.1 to 11% of the population. So almost nobody, or up to 10% of us, right? So the somatic symptom disorder is chronic, and it's fluctuating in its course. And once again, we'll see these people younger than age 30 getting these somatic disorders there. So the person with multiple somatic symptom is not explained medically, right? And oftentimes these guys will reject a psychiatric diagnosis. So they don't want to be diagnosed with somatic symptom disorder. They want to have an explanation for their shortness of breath, or get the attention based on this shortness of breath. For whatever reason they're obtaining it, the attention, or the seeking of a diagnosis, whatever their reason, they are definitely going to be like rejecting that psychiatric diagnosis. And oftentimes these patients will be placed, because they have a really compelling story about their symptoms. They will be on anti-anxiety medications or analgesic medications, or opioids, right? And these patients will actually have an increased risk of suicide as well. So somatic symptom, when you think about this, think physical symptoms, something that we can't touch. So then we have our illness anxiety disorder, and this is formally known as hypochondriasis or hypochondriac, as you guys might have heard in the past. This is estimated to affect 3 to 8% of the population. And so then with these guys, there are few or no somatic symptoms. So the patient is not really complaining too much of the symptoms, but mostly concerned with an anxiety or fear about having or acquiring an illness. So you will see less symptoms and more fear of just the actual having that illness. So an example of this might be, somebody, that had heard of lead poisoning, and while they do not have any symptoms, they are sure that they've had a lead poisoning, or a remote family member has a specific cancer, and the patient will sometimes get some cramping in the gut right before they have diarrhea, so that means they must have this colon cancer, things like that. That's how you want to think of this illness anxiety disorder. They're very highly sensitive to body changes, so any kind of small thing that we have going on in our body is a potential for an anxious event associated with a probable illness, right? And these guys are 3 times more likely to have a personality disorder. Now let's switch gears to conversion disorder, which is now called functional neurological symptom disorder. And we're just going to keep calling this conversion disorder because I want to. So as you guys will now know, this is all called conversion disorder. So this is where Freud believed that anxiety is converted into physical symptoms. So where people will have these kind of more symptoms, in this one you're going to have like these converted signs, stuff we can kind of narrow down here. And this is known to affect 5 to 30% of the population. So examples of these where a patient will come in with like an unexplained paralysis, no voice, or aphonia, right? Seizures, coordination disturbances, difficulty swallowing, urinary retention, echinacea, like not moving, right? Blindness, deafness, double vision, anosmia, which is that no smelling, not able to smell, loss of pain sensation, and hallucinations. And as you can see, these people probably will be spending some time in the hospital with workups, because these are often tied to some of our larger problems, right? So if we have a patient with paralysis, and we're thinking things like stroke or multiple sclerosis. So the patient's probably going to be getting this large workup. And at the end of it all, they don't have any kind of medical explanation for these things. Sometimes at that point in time where they've not found that medical explanation, and they get this diagnosis of conversion disorder, it's hard to take for the patient because this is real to them. They are really having this paralysis moment. And when we tell them that this is a psychiatric disorder, then it could be confusing and frustrating for that patient. But these symptoms usually go away kind of gradually on their own, is what you'll notice. And then the patient gets to do some workup with the exploration of their causes for developing this. We have that the book explains the pseudocysis, which is false pregnancy, and I've actually seen this in motion there. Had a chance to listen to one of our fabulous emergency doctors who had told the patient, I just love the way she worded this. She said, sometimes do you think that you are pregnant and you are not? And I just really liked the way that she said this. It was like non-judgmental, and it allowed the patient to kind of expand. And the patient says, yeah, sometimes that happens. And the doctor said, well, this is the case now, and the patient can actually have, abdominal weight gain and, have convinced all of their friends and family members that they are pregnant, and they actually are not at all. Okay, so moving along, we have our fictitious disorder, and this was formerly called Munchausen syndrome. And there was, the late great Baron Munchausen, which was famous for storytelling. So this is going to be like an intentional lying, intentional storytelling. So the patient no longer has these real true beliefs that something is happening. They're doing this for a purpose. They are consciously lying about something. So they're deliberate, and oftentimes there's that element of compulsion. So they'll have like an obsession and then a compulsion where they have to act this out. And oftentimes these guys too are the same reasons why any of these somatic disorders would seek treatment. They've had some experience getting some good benefits from that sick role, especially like if they didn't have any kind of attention as children in their childhood. They're kind of making up for that love and attention that they're getting by lying about all of this. all of these symptoms there. Or they just really kind of enjoy being cared for once again, or they're coping with a stressful life event. They don't have a clear self of identity. And sometimes it's just kind of the sixth sense of accomplishment and duping physicians. So, all sorts of causes for this, but these are just, like I said, conscious, deliberate lying to gain something. Now we have our fictitious disorder imposed on another, which is also known or formally known as Munchausen by proxy. And this is the one that you'll see quite a bit, in our movies and on our media there, because it's just something that we cannot wrap our heads around when we don't have this factitious disorder. And this is deliberately making our another person ill for our attention-seeking pleasure there. And it is most often perpetrated by mothers against infants, and it accounts for less than 0.04% of reported cases of child abuse in the United States. So while it is extremely rare, it does catch the attention of the population just because of this dramatic story with it. And with any kind of thought that this might be happening, it is in our best interest to go ahead and report that to CPS, and we should be empowered to do so. And remember, there is no problem. You will not be reprimanded if you were wrong, but you do have that obligation to report, guys. Okay, so now we're going to jump ship here and go into our dissociative disorders, and there's 3 of them we're going to look at, and one is called depersonalization derealization disorder. The other one is going to be called dissociative amnesia. And then our third one is going to be our dissociative identity disorder. So some common things about our dissociative disorders. The dissociation is the splitting off of clusters of mental contents from conscious awareness. So we will manifest a dissociation there. And it often evolves out of trauma, like 97% of the time. And then Freud, he's a very popular guy. He had the belief that these are coping mechanisms meant to protect against intrusion. So a means of coping. So our depersonalization, derealization disorder affects 50% of the population on some scale. So that's a large percent. And depersonalization, if you think about your own self, so personal own self. And this is an alteration in the perception or experience of the self so that the feeling of one's own reality is temporarily lost. And I can imagine why this affects 50% of the population, because some people talk about this, right? I just felt out of my own body. And then derealization is that alteration in the perception or experience of the external world. So depersonalization, self, derealization, everything besides yourself, the external world. So that it seems strange or unusual or unreal. So the book goes on to add that the repression of mental contents is believed to protect the patient from extreme emotional pain triggered by either disturbing external circumstances or anxiety-provoking internal urges and feelings. Okay, so on to dissociative amnesia, and it's just more or less, you can guess it based on its name. This is where we have a dissociation, and then some type of amnesia, and it's broken down into a few different areas of amnesia. So we could have localized amnesia, which is kind of the most common, and this is loss of memory of a traumatic event at and or the time surrounding event. So a patient may lose bits and pieces or the whole like traumatic event, and that can happen, especially since our hippocampus is doing a terrible job at that point of storing our memory. We can see how this can be an easy transition into a dissociative event there, a means of coping, as dysfunctional as it is. And then generalized amnesia means that we can't recall any bit of the past. The onset is typically sudden and stress induced. So up until the point that you're talking to the patient, they don't know anything about any bit of their past. And systematized dissociation or amnesia is where they can't recall a category of information. This is like any characteristics of a perpetrator during an assault. So they remember the assault, they just can't remember the perpetrator. Then we have our continuous amnesia, which is forgetting each new event after it's happened. Dissociative fugue is a sudden unexpected travel away from customary places of daily activities. So a patient might have these events where they will start wandering. They may assume a new identity or even forget their own identity and end up in another place. So dissociative identity disorder, or our split personalities here, this is widely disputed as a disorder. I'm just going to leave it at that. I'm not going to put any kind of my own thoughts into this, but just know that it's widely disputed, and it's characterized by the existence of two or more personality states. They also call them alter identities within a single individual. Multiple personalities. In fact, I think they used to call it multiple personality disorder, and now they call it dissociative identity disorder. So each personality is unique and composed of a complex set of memories, behavior patterns, and social relationships, where you might have one person that is named one name and is shy, and then you have another one of these personalities that's outgoing or boisterous. The personalities are known as alters. The only thing really that you need to know about dissociative identity disorder is a treatment called integration. And this is where the psychiatrist and the patient have this really long-term therapy. It's very highly intensive, and it's basically asking the patient to have their personalities really get along with each other. So as you can guess, with our nursing management, especially with our somatic symptom disorder, we have to accept that the symptoms are real to the patient. One of my favorite things when cops come in and ask if a person's raped, I always say, I believe that they were raped. And then it's up to you to figure it out, right? But we have to believe that they believe is what the ultimate lesson I had on that one. And then with our nursing management, we're going to help the build a therapeutic alliance. So do all of our working phases of our therapeutic role there. We're going to help the patient identify stressors because obviously there's lots of these disorders associated with anxiety, stress, and trauma. So we need to identify these stressors and then build that toolkit there for the patients. And then we also put these professional boundaries and we stick to them. So we're going to provide a limited time. So I'm going to tell the patient that they have 10 minutes to discuss their somatic symptoms. And after that, we are not going to give the attention that maybe that they are seeking for these. So that's it. That's all I got for you.